Wellness by Design. I'm your host, Andrew Whitfield Cook. Today we'll be talking with Mary-Louise Condon, a pharmacist who specialises in compounding for not just naturopaths but pharmacists as well. Welcome to Wellness by Design's Mary-Lou. How are you?
I'm great, Andrew.
And thank you for the invitation.
Oh no, call me Lou. Call me Lou, please. I love it. We're very informal.
Cool. Okay, sweet. So, look, thanks so much for joining us today. Can you first take us through a little bit of your history? Tell us how you arrived from being, a pharmacist who sells normally pre-formulated drugs these days. In the old days, it was different. What sparked your interest in compounding?
Yeah, look, Andrew, I had a wonderful opportunity when I've studied at UQ in Queensland. For those of you who don't know, I'm a happy Brisbane girl. And at that opportunity, I got a scholarship to go to the US to study. And at that opportunity, I learned a whole new skill of compounding. And look, I'm going to take you way back. This is 25 years ago. But it sort of opened my eyes to looking at medicines as N=1, about the individual, not about a whole bracket of the population. So I learned that in the US, and it ignited my passion, came back to Australia, went on to do diverse things, but basically opened up my compounding business over 25 years ago in Brisbane. And then it's just morphed into what I'm passionate about and what happened in my life. So what am I passionate about? I'm really passionate about nutraceuticals and nutrient balancing. I'm very passionate about hormone restoration and wellness. So from compounding from me is really looking at an individual and nurturing them to better health. So it's just not saying, hey, you're deficient in this. It's like, well, what else is around that? So compounding has come a long way from me. It's just not medicines. It's nutraceuticals, it's pharmaceuticals, and it's looking at the dose, the delivery, and everything. So look, I love compounding. I'm a big advocate of not only getting more pharmacists involved in it, but in making sure they're educated.
But indeed, this is the history of pharmacy. I mean, pharmacists used to very commonly make up, Whitfield's ointment was a cracker, but there were many that were bespoke medicines.
Yeah, look, compounding is the art of pharmacy, or at least we used to be chemists, didn't we? And now we're pharmacists because we're pharmaceutical chemists. But however, it's the art of, it's cooking in a dispensary. And I always train my young pharmacists to follow the recipe and then enhance it the best way they can when they have the knowledge. But obviously going back to the roots of what we're doing and how we're trying to achieve it, because, there's so many things available to us that are not on prescription. They might be a medical grade food or a supplement that are at everyone's fingertips, that just knowledge is power. And I want to get that message out there. So let's go back to, the art of manufacturing or the art of bespoke compounding for the individual is what it's all about now. But I think it's probably the podcast is about awareness. And if any of your listenings, whether they're pharmacists, naturopaths, doctors alike, if they haven't got a compounding pharmacist in their best friend list, go find one. And hopefully maybe today we can just excite your listeners to do that.
Well, take us through some of the nutrients you use and what are the major issues that present you? Like, for instance, certain B vitamins are sensitive to light, acid, alkali, that sort of thing. So can we discuss what you use and the issues around them?
Yeah, look, we're really fortunate. In my business, we've morphed into not just compounding capsules and tablets and suspensions, but we do injectables as well. So there's some nutrients that just far superior when you give us an injection versus orally, but even transdermally. We had a chat the other day that so many naturopaths don't understand. We can do transdermal nutrients, which is just a great opportunity for pediatric populations, geriatric populations. How about the epidemic of people with gut issues who just don't absorb nutrients? And that's a whole new story, isn't it? So anyway, what's available to you? We take pride in understanding it is a science and it's a skill, and it's something that, look, I'm learning still today, and I've been studying compounding for over 25 years, but it's understanding we're looking at the patient's best outcome and how do we achieve that. So you mentioned B group vitamins and obviously nutraceuticals. I'm a big fan of B group vitamins, but probably the B vitamin I love would have to be an AD. And that's a B3 analog, and that's nicotinamide adenoside dinucleotide. And we had a chat about that. So that is such a powerful mitochondrial nutrient that really, up until recently, wasn't available because it's highly unstable. It must be refrigerated, and it's poorly orally absorbed. And here we have it now. We can inject it. We can do it intranasally, and we're just now morphing into precursors, which are oral. So it's a good one.
Okay, so there's another route of delivery that I very often just totally overlook: nasal delivery. But can we first cover? You just mentioned about poor oral absorption, and when we speak about nutritional compounds like glucosamine, chondroitin, even B6, we're looking around that 20 to 40% absorption. How does that compare to, say, dermal absorption? B, just because it's 20% or 40% doesn't mean it doesn't work. It just means that's what the percentage absorption is. So you've got to adjust dose accordingly, correct?
Yeah, totally. I suppose every nutrient we can bring out clinical studies to say oral absorption versus transdermal versus intramuscular or IV. Some things you're just not going to go transdermal. We do often go to the basic rule of adult size. And then even if I make it micronized or in a nanoparticle, it still may never get transdermal absorption. However, we've moved a long way, even in oral therapy now, haven't we, talking about liposomal products. And I think the availability of them in so many nutraceuticals companies is just fantastic. I love it. We also have the capability of emulsifying in our laboratory or changing the molecular size of a product. Often we might get a raw ingredient and we will micronize it. So we have equipment that's available to us now, certainly with sound therapy, to change that molecule. So, sorry, I have deviated there. For the delivery form, there is certainly distinguishes. And for those listeners that are interested, we actually publish a list to practitioners, and it talks about the difference just that on whatever nutrient you're looking for. So, for example, let's talk about B6. You used it, and the oral bioavailability is diminished, and therefore you have to dose higher. You have to dose more frequently. But an injection, well, that's nearly 96% availability to a client. So, of course, for that one, I might say, if you have that available in your armamentarium or way to refer, that's obviously going to be a great opportunity for you. But B6 is also transdermal as well. So, highly bright colour, B6, and we're going to talk about that. So, therefore, you might look at some methods and we can do that. We can also use the PESRI as well. So, that's a beautiful compound that you can give many ways. I know we're also talking about some other B group vitamins, but the combination of Bs, how many times with mental health now we do many combinational Bs, just not the B6. You might do B1, B2, in particular with a B3 analog, if you're talking about pyrrole disorders. So therefore, that nutrient dispensing is looking at the right combination of Bs put together and the dosing of it. So, I mean, that's a great question. I hope I sort of covered where we come from that. But the stability of it is so important.
So that's another area. So I was just going to ask, when you're blending nutritional compounds and you've got different technical aspects for each of them. I mean, you've even got different mesh sizes, I would imagine, or you're talking about Dalton sizes. So each molecule has got its own particular size. Forgive me, that's in the molecule. Let's say in the powder that you're administering it. And let's talk about oral absorption, right? So if you're mixing a powder, they're going to be different weights, different acid alkali, different dissociation curves, all of that sort of thing. How do you then sort of maneuver to have not just good oral absorption but good effect?
Yeah, do you know what? That's the perfect question there, isn't it? Because if we're looking at N=1, and that's the individual and the client, that whether a naturopath, we're going to help them nutrient balance, or we're going to test pre and post. So knowing that, obviously knowing how they go into the scenario and what I'm trying to achieve to balance them back, I'm going to retest 3 months after it to see if I've actually validated and got the answer I need, and that's nutrient balance. However, what you're actually saying is when we make a product, to make sure it's the best product for the person, we have a huge library internationally with compounding that when I often do a formula, it's not me making a formula. I'm going to the whole world of the library, and through the internet and through databases, we collaborate, and we do this all the time, particularly when we have new compounds and nutraceuticals. And often you find it's this early innovation that you then find vitamin companies picking it up and running with it as a commercial product. So I think the validation of compounders in this world is really, really important. But saying that, how we mix it, we're very anal. So if I'm looking at a mixed powder, I'm going to make sure they're pretty much all similar size, and we can do that by shear force now, sound wave therapy, and then we then remix. And we do that, yeah. So we do sound wave technology. I would love to think I've still got the classic mortar and pestle. I've still got several on my bench here. I don't think they've been used in years.
That's more for the
we call
herb.
them. Yeah, totally. Well, look, if
More
you
for
want to do it, I
culinary,
suppose. Yeah. So therefore, we use sound wave therapy now for mixing.
Tell me more about that. That's really interesting. Sound wave therapy, or sound wave mixing.
Yes.
Sorry. So
sound wave mixing. So we're obviously the electric mortar and pestle. We actually do have an electric mortar and pestle. So we never would use a traditional one, and it spare its force and it agitates the product so they emulsify or they blend. So we might use that for a powder or an emulsion or a suspension. However, now this is actually NASA technology. We have a device that we could put powders or an emulsion into it, that it's called a resonated sound wave that mixes at shear force. So it vibrates so fast, Andrew, your eye would not see it. It actually looks often that it doesn't even move, but you can hear the vibrations. Pretty fancy.
Fascinating. So do you then encapsulate the product so that it's in a dose format?
Yeah, perfect example. Every product we do would always then go on to do something to it. So we're going to mix it by sound wave therapy or sound wave to make it easier for you. Then we're going to encapsulate, or then we might suspend it into a suspension, or whatever we intend to do, the ultimate product. It might go into transdermal, oral, however we end up doing it. So for particularly, let's bring it down to what we do compound a lot. We spoke about nutrient therapy, particularly for transdermal. We would micronize those products, mix them uniformly using sound, and then we put them into a vehicle that allows better penetration. And this is actually a wonderful area too, Andrew. I love these bases. It is a lot about the base now, okay? So I would love to say aqueous and sorboline were common words. They are not. We just don't use them. We have so many wonderful bases at our fingertips. And we now would know through education which product we want to mix and then incorporate into the right base. And you know what? For many of your naturopaths listening, we are very passionate about the microbiome on the skin. And that means making the pH of the transdermal product match that of the client. And, as much as I say I love anti-aging and we do a lot of nutrient therapy, your skin biome particularly is such an important part of your body. So therefore, we would also incorporate a skin biome friendly formula. And yes, we put probiotics in them, very much so. We add a lot of probiotics to formulations with capsules now, and we use many probiotics in combination with skin therapy.
Just a point of the cream.
Yes.
When we're delivering oral vitamins or minerals, we get hung up on the mineral itself and pay very little attention to the ligand that it's attached to, which can have dramatic consequences in how that mineral is used. For instance, magnesium oxide is the classic versus magnesium orotate bisglycinate. They have different actions. What about the carrier of a cream? Does that have a different action for the mineral within?
Absolutely. So we might use a cream that it's a very plasticized base, meaning heavily in the fat. So therefore, that's going to be an optimal vehicle if I want to drive it through the epidermis and get it into a blood level, okay? If I want something to sit on the skin, I'm probably going to use more of a water-based product. But we actually are really fortunate now. We have so many versatile bases, and we actually call them that. And a versatile base is a bit forgiving. You can use a bit of both, And what would that be, for example, if I was going to use a nutraceutical cream for treating pyrroles? That has a combination of fat-soluble vitamins, A, Ds, and Es. It's got water-soluble vitamins, your Bs, your B2, your B6, and it's got minerals such as zinc. So therefore, this cream has to be quite versatile, and we would use one. But it would be the process and the time we add them in together to make sure they're encapsulated and they're carried uniformly throughout that cream. So I hope that answered that, but we do many different bases there. And of course, testing, I've got to say I'm very passionate about education and testing. It's testing the product in the day. So the testing's not just at a patient level to make sure it's working. And often they will tell you before you test, but also to see the cream and it's stable in a format. So we do a lot of testing testing that the product is stable for at least 3 months if it's transdermal, and of course, so it doesn't have any microbial growth. And then that's often just achieved by simply balancing the cream back to a microbiome-friendly pH, maybe 4.5, 5. And then the other addition might be looking at probably just how they store it at home. You know, obviously when we compound a product, we have different regulations with our complex compounding rules. And, you know, that's a really interesting space. We are under huge changes in our industry. And I think they're for good and bad reasons. The good reason is I don't think you can come into this industry now being uneducated and a bit of a cowboy. I think now we understand we have complex compounding rules. So what would be the difference for someone listening? I could be a simple compounder, meaning if you walk into my pharmacy and I just did a simple cream on the bench, there's limitations on what you can do now. I sit in a space of complex compounding, and what that means for complex compounders out there is that we know the validation of what a hazard is to our risk to our clients, risk to our patients, that is, risk to the prescriber, and risk to obviously my staff and my A team, because I don't want them at risk either. And a natural example of that might be if I'm working with a hormone, which is a hazard, isn't it, for breathing, transdermal and whatnot. So we'd have to make sure the risk is looked after there. But even microdosing, if I'm making something microdosed, I want to make sure what's in there is really in there. And the classic example for that, Andrew, you may be familiar with, would be thyroid extract or thyroid T3.
Yep.
A highly unstable hormone, you know, and not only that's microdosed. So I would want to validate when I make a T3 capsule that exactly has what's in it. So we send it off for post-testing. That's validation testing. And we do that with every team leader in a section every year to make sure that we can endorse them as a good technician and they make a quality product. And that's really important for the prescriber to know, the patient to know, and the industry as a whole.
I was going to ask a 20-pronged question now, but I'll try and keep the thing. Well, with regards to accreditation, accreditation issues, I mean, obviously there's safety issues are a huge issue, but also you're talking about competency in mixing standards and not just putting stuff in, but actually measuring that they're there at the end and for the patient to be able to use. So Can you take us through accreditation, what that entails?
Sure. So this is, as I said, a really dynamic area. So I know I spoke a little bit about where I see the future of pharmacy. I've been passionately involved in compounding pharmacy in Australia for 25 years, and I hope to not retire in the near future, maybe 10 or 20 to go. We collectively as a group are uniting, and we're actually going to come back and really put our stripes on the table to patients and physicians and referrers such as naturopaths or physios or whatever, and say we are about training. And we are actually formulating a group called Formula. That means any complex compounding pharmacist can join at free of charge, and they will have access to this wealth of information. So education is at the forefront of that. And then knowing that there's procedures and standard operating procedures that they must adhere to make sure everyone is doing it safely. And risk management is at the front of everyone's mind, isn't it? Everything we do now. But I don't want to see us over-regulated to think that we get to a point that we become a pharmaceutical company, because we're not. We're about the individual. We're about, you have a client, Andrew, that you have a problem that you need to solve. And I hope you pick up the phone and you reach out to your compounding pharmacist and go, look, help me. How do I get this active, whether it be a nutraceutical or a pharmaceutical, into my patient effectively, safely, and have a positive outcome? So we're very aware of those. So obviously then with these regulations, I hope I'm not talking on as a bit boring, is a story that you and I could sit down in a year's time and say, look, this is happening. Industry's changed, and it will, and it's happening. But it's not supply driven. You know, it's not someone who I buy my ingredients from telling me, of course they tell me how to store it. Of course they tell me the shelf life and the expiry. And of course we adhere to that any day. And we're going to pass it on to patients. But it's about looking at my brethren, my fellow compounders, my pharmacists, and walk beside them and say, there's a better way, but do it safely and make sure we all unite on this way. And I think we've learned from international trends that you just can't be rogue and you've got to do it safely.
I think what you're talking about is accreditation without pecuniary interest in it. Is that right?
Yeah, exactly.
Yeah. Can I just go back to something that you said? Oh, sorry, Lynn.
No. In elaborating from that, it would be mandatory education, but not an expense for money. It's about educating for the right reasons. And look, to be honest, I have the opportunity of working with a lot of pharmacy programs in this country, and the amount of time spent on teaching compounding as an art is really limited. Now, I'm not here to bag pharmacy at all, because I love pharmacy. Like, I'm very passionate, but unfortunately, in a 4-year course, you can only learn so much. You have to learn about the actives, you have to learn about nutraceuticals, and at the end of the day, how much time spent on compounding is limited. So I'm very proactive in taking pharmacists in their final year, and we have a rotational program where they come into our facility and they learn, and they spend 6 weeks with me. And it's unfortunate that the main pharmacists who do it, the ones studying PhD, who go on to work for big pharma. I want to see more community pharmacists get involved. Of course, hospital pharmacy do all the time, but not community. But community is where the growth in compounding is, so they need to know more about it. And sorry for interrupting you.
No, that's okay. Is the APF text still used in the pharmacy course at UQ?
Yes,
it is?
We still use the APF. It's limited. The APF is used. However, I suppose in my facility, we do many types of compounding. So we grade them into different areas. So, of course, we do sterile compounding. We do hazardous compounding like the hormones. We also do non-hazardous and basic nutraceuticals. So the APF doesn't pick up all those areas into its entirety. So we have many different bodies that we lean on to guide us to get the best outcome. But the APF is still, yes, very much used, and it still has an effect on how we often might do a basic formula.
Good old Tink Ben's Co.
No, we don't use that.
Just going back to what you said earlier, and you were talking about the creams and the stability of the nutrients in it. I remember, this is some years ago now, and it was a hospital pharmacist looking at the vitamin D that they used to make for their kids. And they found that they had, I think it was a 12-week expiry date, because they didn't use preservatives in the formula. And so therefore, I think it was bacteria kept on eating or disintegrating the vitamin D into its base complexes. I think that was the story. So how do you get around that? Or do you have to work within that? Like, if you made it, let's say, a vitamin D for the skin, do you have to say, okay, it's only valid for 12 weeks, and after that, the drop-off is just too much?
Very much so. So these are the groups that we align with internationally. So if I was going to use an APF guided formula, I'm only going to give 28 days, because that wouldn't have any extended expiry or stability on it. But vitamin D is such a beautiful product, and it can be given orally. It can be given transdermally. It can be given intramuscularly. Biggest growth for us is vitamin D injections now. So looking at that vitamin D cream, I actually have the pleasure of working with a New Zealand pharmacist who's no longer with us, Mike, and he actually has stability of vitamin D cream up to 12 months. But it's very much on how you get that preparation. Yeah, I know. So unfortunately, it never got to the market, because by the time you make that product, and vitamin D is very well taken orally, and it's absorbed at the right dose, that it was not a commercial venture. However, you do actually have a stable vitamin D called Solar D on the market, which was actually designed by a compounding chemist in Perth. I don't know if you've heard of it. So what would we do? We have a bank. If for using vitamin D as an example, if I think I want to go out there and find a formula, I'm not going to sit down. Obviously, I've got a lot of knowledge with compounding. However, I would use a resource from me. So I would use my supplying companies who help us do stability testing all the time. So it might be PCCA, it might be Medisca, or it might be an international compounding society, which I get involved with very often. If I can't find a legacy or a formula from the IJCP or those groups, I might put it out to the big bad world and ask my peers, and we do that often on a network group, and I might say, look, I'm challenged by this formula. I want to get some stability data that's greater than 28 days. Now, if I was to dispense that and have 28 days, I would have to then validate that internally. So meaning at 28 days, I'd make it and I would resend it off for testing. So, but I think the intent with compounded products is to make and use straight away. The intent is not to make a compound and sit it on the shelf to dispense or sell on at a later date, because that really is manufacture. We are clearly different from manufacturing. So,
cool.
Caught. Were you going to say, why didn't you say that beforehand?
No,
Sorry,
I was
we
just,
aren't manufacturing.
why wasn't my mind there? It's of course.
Oh, no. But the thing is, what if it would be the volume of the product? Because obviously if you're only using 1 gram a day and I'm giving you a 100-gram tube, well, that's 3 months supply. So that product in particular, I may wish to go and search the big bad internet and all our journals of literature and formulation to find one which lasts at least 3 months. And that's what I would do. So therefore, when you purchase the product, it's going to last the 3 months. Many of the creams we do last for 3 months. And I would say probably in saying that, with your pH, with the type of preservative we use, we get asked so often now, Andrew, for natural preservatives. So that would be a real growth with compounding. I think people are very aware of, we don't want these preservative products that are not really made for a microbiome skin-friendly person. So that, we often use basic citric acid or a product that we bring the pH down to, and we use some low-dose probiotic therapy in that cream to make it more microbiome friendly, and therefore, and it tends to be stable. So most of the creams we do would have 3 months.
I've got to say, when I first heard about transdermal absorption of nutrients, I was blown away because I thought, no way can it get through the skin. But I'm wondering if you do baseline testing and then treatment level testing to prove that you've gotten that formula through the skin and are affecting the serum levels of the patient. Do you enter into that at all?
Well,
or is that done by the practitioner?
Well, no, they're done by both. We offer both services, but we also love to align with practitioners. So a practitioner is always going to retest after 3 to 6 months. But look at zinc, for example. There's so many chelated versions of zinc out there, whether, doing transdermal or oral. But if we're going to use zinc transdermally, you can see a clear difference after 6 weeks of therapy. So how we might do a quick test is we use a device called an oligoscan, and that just looks at refractive light that comes out through the skin itself, and it gives you a clear change. I would say within 3 months with zinc, and iron, some of the heavy minerals. So you can see a difference absolutely from transdermal therapy. The question I would say, if you don't, I would go back to dosing, and I'd go back to the integrity of the skin. And this is often when we do nutraceutical compounding, it's just about the person as the entirety, not about the nutrient. So fix their fatty acid synthesis. You might want to pick something to rehydrate the skin layer from internally and externally, and then look at nutrient therapy. We often use with kids, there's an old adage, love a good story, because some of these creams are quite bright in colour. We get them to put on the soles of their feet and wear a sock. So they're warm at night, winter's great, they're not going to stain the sheets at all, and they get great absorption. And mums will tell you that certainly when we're treating about mood or mental health and anxiety, they see kids settle within 2 to 3 weeks. So, that's just a beautiful outcome. So really testing for the sake of the improvement, I would go on symptoms more than that. But we offer testing for our facility here to our clients. And we also work with practitioners all the time. And they might send us an update and they go, look, we started with this formula. If they're going to use bloods, for example, we've got to this level, they tell us their desired outcome, and we might write down a strategy of how they can best get there. It might going back to a liquid in a zinc format, sometimes going to concentrated liquid when someone has a lot of gut issues, the epidemic of IBS and gut overgrowth, whether it be Helicobacter pylori or strep or staph, wonderful opportunity to go back to a liquid dropper form.
Do you ever use a very rarely talked about form of zinc acetate? It's normally reserved for Wilson's disease. Have you ever used it in Australia?
We certainly stock it. There you go. I'll give you that answer. Yeah. Do we use it? No, we don't use it often. It's probably you could tell me why we don't use it. I think it's the opportunity to use. I think what we do, we go back to our practitioners and they get often very comfortable in the zinc form chelates they understand and they know.
But to me, it's curious to me why zinc acetate was the form preferred for Wilson's disease. Obviously, that's a copper overload condition. And, copper accumulates in the brain tissue. But to me, it's very interesting why it was never investigated for disorders like, for instance, anorexia nervosa, where there is allegedly, and I may be wrong here, allegedly a flip in the zinc absorption mechanism. Is it in the brain? I don't know where they've looked. This was Reading University research many, many years ago. I just don't know why it's never been investigated for other uses.
Yeah. Would it be to the conversion of formaldehyde? Would it be something about then the usage and the uptake of zinc itself? Yeah, I know. It's that. Look, I'm going to find out for us. That's a great question. For at the moment, probably the main zinc we do a lot of a zinc picolinate tends to be, or zinc glycinate tends to be where people sit these days for a safe chelated zinc. But the zinc acetate we do have. So anyone listening and they want to formulate a zinc acetate product, send it on over, and we'll certainly get something for you. Yeah. The Wilson's disease with the copper, copper and zinc ratio is really hit to the forefront with nutraceutical compounding because of pyrroles and nutrient balancing. And this is where you can really see a difference with symptom control. And I always challenge certainly naturopaths or practitioners to use multi-modalities, just not one, because often you don't know. And I think the biggest failure we have as consultants and clinicians is people who don't get an immediate response don't come back, or they don't get an immediate response and they're not going to tell you, and you don't get the outcome you want for what are you treating, whether it be anxiety or mood disorders or some sort of eating disorder. So using a multimodality, whether it be a cream, a capsule, drops, is sometimes not a bad idea, because we all know, particularly for zinc, if I was going to dose it, the best therapeutic dosing is going to be a 3 times a day interval, not a once a day. And it's going to be a smaller dose because we know the uptake of oral zinc. Look, I read a paper really, after about 13 to 15 milligram, the oral uptake of zinc is really diminished. And you could certainly challenge and bring some great studies and educate me, and I'd love it. But therefore, if you're going to do it 3 times a day dosing, compliance becomes an issue. So you might morph into a program where you can have a cream, a drop, and a capsule. Bring you many ways.
Okay. Now I've got to ask, do you have a favourite condition that you love to manage with compounding?
Yeah, I do. Well, I suppose from my journey, I love a good story, Andrew, but my story is that I tragically, about 10 years ago, I'd say tragically, got diagnosed with Hashimoto's. And it came to the point, I always joke, I was in the dispensary one day, I was so fatigued, I had brain fog. I kept going to the doctors and they said, you're fine, you're beautiful, you're healthy. And I said, there is something wrong. And I even live in this space. I was making thyroid extracts and whatnot. Eventually did the antibodies level and said, wow. So for thyroid, for me, it's a big passion. I love thyroid. And hence why the nutraceuticals I love are vitamin D. We all know the interconnection with autoimmunity and vitamin D, VDR receptor, genetic receptors. I love balancing back the vitamins that you need. And the number one mineral most people forget with thyroid is iron. Iron can be infused. Iron can be taken orally. You get a 6-month window. You can use iron transdermally. You can have iron in a pessary. And of course a liquid. And it's using different forms to nutrient balance these people. And then it's using anti-inflammatories, which are natural. And that's morphing into what I see with thyroid clients is pain. Fibromyalgia, other autoimmunity. So I have been really fortunate to work with clinical trials with a beautiful product called PEA. I know we spoke about that. Yes. I think, PEA is available with many great companies out now, but go eyes wide open. There's many forms of PEA. You get micronized. You get a PEA, which is emulsified, called Levogen. You get a PEA plus, which is more water soluble, with someone who has a gut dysbiosis you'd go for. So PEA is certainly a beautiful product. I've had the privilege of doing clinical trial work out of UQ with Dr. Beth Steeles. So a lot of the papers you're reading now, we've helped bring that product to the market. So I've been working with PEA for 8 years, and to see it now commercially available by many nutraceutical companies is really just so wonderful. So where I stem that back to thyroid disorders, we see so much inflammation that sometimes doesn't have to be treated with thyroid hormone. Treat the inflammation, treat the root cause, and PEA and now CBD are wonderful products. So I love
Tell us a little bit more. Tell us a little bit more about PEA, because you're talking about different absorptions here or different formulations. And if you're giving all of them orally, do you find, like you mentioned, that one form might be better suited to somebody with SIBO, whereas another one would be better suited for somebody with, let's say, gallbladder insufficiency or a history of gallbladder disease?
Yeah, I love the way you've hit on the head. So those different forms of PEA, that's perfectly the answer. Some of the gallbladder, I'm probably not going to give a liposomal or lipospheric PEA. I'd probably do the water-soluble version because their ability to break down fat generally is reduced. The SIBO, isn't this wonderful? They're actually doing a trial now with PEA on SIBO as an anti-inflammatory. So understanding PEA, for anyone listening, and I'm sure you might be doing another podcast on it, but it works like a cannabinoid, a CBD1 agonist. And we all know now our general acceptance of CBD, not just CBD itself, but supporting your cannabidiol system for anti-inflammatories because it's natural to us. It's what we have. So we're very privileged in our business that we compound a lot of CBD products now, and we just don't do them orally, we do them transdermally, and they work. But bringing back the PEA, you've got your different formalities. So please, any clinicians reach out. We can tell you the types of PEA you can get. And if you're going to look at a commercial product, just check what type it is. But I'm a big supporter of Levogen, and they now have a Levogen Plus. Not because I've done the clinical work trials on it, but you've got one which is a fatty base and one which is a water soluble. So you're sort of getting both formalities.
Gotcha.
So the fatty base Levogen, we do put in a transdermal product, and I really hope to see that commercially available on the market in the next few years. At the moment, it is readily compounded by us, but it will evolve into a product that will be. So head-to-head to Nurofen topically. I mean, how often do people go into a pharmacy, Andrew, and grab Voltaren or grab Nurofen?
With ibuprofen.
No, it's just the wrong answer. I know I'm talking to the converted, which is you, and you're passionate about health as much as I am, but you're not deficient in Nurofen receptors. Help your own anti-inflammatories, help them, and that's PEA, and that's CBD1.
Just a practical thing on application of PEA topically. Yeah. One of the TV ads that used to annoy the hell out of me was a locally applied non-steroidal anti-inflammatory gel or cream, which purported to go directly to the site of action. The inference was that it didn't go anywhere else in the body. Any hospital pharmacist will tell you about the issues of ulcers in kids that they're having to see because the well-meaning parents have rubbed, these creams or gels on the rheumatic joints of these children. Tell us a little bit more about PEA. Can you get let's say more of a local action, and let's say it's a sore elbow. If you applied a PEA cream locally, can you get more of an action locally as well as dispensing around the body?
You can, and you would obviously do that. So if we were going to use it for a muscular or a joint inflammation condition, you would certainly apply directly to the root cause of the part of the body which is in pain. But there's nothing stopped. We can use it as a delivery vehicle as well, but I would use a powder with the child as well. So I'd use both. I'd use topical and the oral supplement. But knowing that your body naturally makes this compound, okay? So all by doing it is enabling your body to deal with the inflammation. So absolutely. And look, this is a great question. So I might have to go back to Dr. Beth and go, hey, look, when we do this transdermal trial, maybe we should put in, rather than just doing symptomatic improvement, maybe we should look at blood levels, which we did with oral therapy. But a lot of the trials are really done on pain modulation. But it's a compound that's just got I can't see any indications. It's neuropathic pain, it's joint pain, muscular pain. We're now seeing it in gut inflammation disorders. We're seeing for dental pain. We're seeing it for fibromyalgic pain. We're seeing it for, give me an inflammation condition that you want to treat, eczema, skin dermatitis, many, many areas that we're using PEA that, I think, and now the combination with turmeric or curcumin is certainly a wonderful sort of advancement on that. So that is what you're now going to be seeing in nutraceutical land commercially available. which is some liposomal turmeric or curcumin with it.
I just hope that PEA, unlike curcumin, avoids the pigeonholing that curcumin got. Like, it's for joints, whereas curcumin is for so much more, as PEA.
Absolutely. Yeah, absolutely. I think it is. And I think, the beautiful thing we're seeing is long-term use of PEA. There's been no downside. I think in one of the trials earlier on, which was done, there was one lady that we were suspicious was having an effect on her white blood cells. And at the end of the day, it was polypharmacy that did it. So we couldn't even definitively say that PEA had an influence, which is really encouraging. And I think that's important to know, anyone who's using PEA. The other thing is the dose spectrum is quite broad. This is something that you could use with 150 milligrams 3 times a day, up to 600 milligrams 3 times a day. So therefore, and even the higher doses, you're not seeing any side effects. So probably the only side effects you might get is the loose stool, and therefore you would know that to pull
anything you give
down.
Yeah,
exactly. So that's gastrointolerance. So therefore, that's really encouraging. So we always have the mantra, start low and go slow, but you'd find the dose. So certainly for pediatrics, you can suspend it in water. You get the powder, you put in water, you can open the capsules and put them on water. And the most important thing is transdermally now is another option. Certainly for kids with, I'm going to say, we didn't probably not pigeoning your turmeric, which you spoke about, but we are actually doing a study with PEA and mood, because mood and anxiety is an inflammation disorder. So we know oral PEA is a systemic anti-inflammatory. So why not? Why do we often get so fixated with, obviously nutrient balancing pyrrols is important, but PEA, I know, for mood disorder, well, watch this space. If any clinicians watching, give it a go.
Okay, so for anybody out there wanting to learn more about compounding, what sort of resources do you have? Where would you recommend? Given that you're a pharmacist, so you're in really that pharmacy arena, but what about naturopaths? Can they learn about this?
Oh my goodness. So we do a lot of education with educational bodies that align with where you're from. So my background, from what I finished in compounding pharmacy, I went on to do a course with anti-aging medicine, and that was an advanced diplomat I did in the US. So we align with a company in Australia called A5M, which is an A4M feeder. We also would align with people like ACNM and the Australian Society of Integrative Medicine, or wherever you align with. So for naturopaths at the moment, most of the naturopaths, it's whatever body you're aligned to, they would then align with a compounding arm. Now, I'm going to say probably the easiest way is these courses are run probably not as frequently as we'd like because of COVID. And so I would say at the moment, a lot of it's gone on to telehealth or webinars or podcasts like this. However, we have a whole gamut of educational videos with our business that we always share. So on our website, you log in as a practitioner, and there's a resource area that you log into and have access to. So we don't sort of discriminate for different modalities at the moment. So we ask for your APRA registration, and so we know you're fully fledged and you're passionate about this. And then once you log in, you would see resources. And if there's not the resource that you're looking for, we encourage you to send us an email, and we might have had a past tutorial. So this is the group that I sort of expressed to you where we're heading with compounding, called Formulae, is these videos will be very much marketed to every health practitioner, just not pharmacists, because they're about looking at the whole symptom and the person and what age they're at. So, when we talk about PEA or CBD, it's the stage of life and the disorder you bring with that. And that's also quite important. So, and what rocks your boat, what you're trying to achieve.
There would be.
So education's big.
There is no. Sorry, you go.
Oh, no. So, yes, we have resources. Your compounding pharmacists that are complex compounders, many of us have resources, and it's who we align with. So, if you would send us an email, we could direct you to who we align with education. In addition, if we don't have a video in our resource library, we would certainly send them out to you. But education is a big part, and to partner with someone who you can get the right answers for with your clients is really, really important.
Great. Lou, there is so much more to cover here. I would love to delve into another area if you'd be amenable to join us back on Wellness by Designs another time. Pretty please.
Oh, I'd love that. Oh, I'd love it. I think maybe, I had the opportunity with DHF to talk about thyroid last year, and the feedback was phenomenal. So, but I'm going to go away and do my homework on the zinc.
Yeah, all right. Cool.
Maybe there's.
Well, maybe we can delve further into thyroid a little bit later, and we can, as a sideline, we'll delve into what are the various I was going to say chelates, but compounds of zinc that are, and how you utilize them.
Yes.
Great.
Please do.
Mary-Louise Condon, thank you so much for joining us on Wellness by Designs today and sharing just a little bit of the expertise and passion that you have for compounding and how we can use it to help our patients. Thanks so much for joining us today.
Thank you, Andrew. I've really enjoyed it. Thanks.
And of course, thank you for joining us today. You can find all of the resources and show notes and other podcasts on the designsforhealth.com.au website. Thanks so much again for joining us. I'm Andrew Whitfield Cook. This is Wellness by Designs.